Yes, good morning or good afternoon, depending on when you're watching this, of course. This is a lecture for Introduction to Psychology on the chapter, usually one of the last chapters in your textbooks, about psychotherapy. A comprehensive uh, lecture for that chapter. We will go through a couple of ideas, defining what is therapy, history of therapy, or social contracts to take care of the mentally ill, serious mentally ill, and then various types of therapies. But we really need to define what is psychotherapy in general. And of course, what we would have to say is that psychotherapy is some sort of systematic interaction between a therapist and a client. In other words, there's two people in this relationship, a professional and a consumer. And it can be done usually for one of three main purposes or three main populations, right? It will apply the psychological principles, stuff we have learned in psychology and through psychotherapy, with a goal. And that goal is to affect the client's thoughts, feelings, and behaviors, or behaviors in one way or another, in order to address certain categories of problems, which will also therefore be certain categories of people, psychologically speaking. The first one is to help clients overcome psychological disorders, major mental disorders, schizophrenia, bipolar disorders, anxiety disorders, etc., those that we've covered in previous chapters. This can include the population of people who do not integrate into society and are disturbed to the point where it's making it difficult for them to actually function as a fully functioning member of society. The other population is something more, what we call the neurotic population, the suggesting to problems in living. This is what actually most of us can use psychotherapy for. You have a hard time, a difficult marriage, anger management issues, things that you can still function pretty well in society, but we really need to find better solutions in our everyday lives and how we are coping with these stresses and hassles of everyday living. And the third type of population, a third type of reason for going to therapy, is simply individual development. People who are not looking to address problems per se, but find that psychotherapy will help them to adjust as a happy and fulfilled type of person. So, psychotherapy generally will be talking about those three possibilities and try to just use three different categories of problems. And I want to talk about that first group of people, that the psychotic individuals, the people who cannot integrate inside of people who become angry and aggressive for various psychological or biological illnesses. These are obviously people who, since they cannot integrate into society, become a problem for society in one way or the other. And they have always been around, and there's always been a problem. So let's sort of talk about here the history of therapies. First, of what happens before the modern times. Mainly, very often, they would think of people as possessed by demons or spirits, and the treatment reflected demonological thinking. In other words, trying to in some way take the evil spirits out of the person. We have here a picture of a Catholic exorcism, but there was, of course, exorcisms of different sorts in almost every culture. And sometimes these would include very, very unusual or difficult systems, dunking witches into the water. Very often, there were, in order to allow the voices to or the demons to escape from the head, there were People would have holes drilled into their skulls, various things that would happen. Now, of course, with the onset of the Enlightenment and the decline of religiosity in Europe, they that did nothing to alleviate the problem of the seriously mentally ill within the society, but they could not blame it anymore on demons or spirits. So and with no other solution, what happened was that societies, France, England, the earlier the United States, built asylums, which were not really any way for treatment. There was no concept of treatment at the time. So they warehoused them. And often, because you have a lot of people in a small area, and many of them can be aggressive and angry, they were merely chained to walls and fed a minimal, usually not very healthy type of food at all, abused, etc. So the asylums were really just to take these people out of society. Of course, that did not help their ascent to wellness at all. And sometime around the beginning of the 19th century, 1800s, they became a humanitarian reform. In Paris, the first one actually, Philippe Pinel, where this is a picture of Pinel, looked for reform. Basically, his basic innovation was to take these people out of chains and let them have some fresh air. This was followed in England by a fellow named William Tuke at Bedlam Hospital. You've heard the word Bedlam. It sounds like Bedlam in there. Bedlam was actually a name of a hospital, a mental hospital or asylum, actually, an insane asylum. And William Tuke was the person who followed in Philippe Pinel's footsteps in London. And in the United States, it was Dorothea Dix in the 1820s, 1830s through the 1880s. She was active. I think she passed away in 1882. Not exactly sure about that date. And she was particularly active in the humanitarian reforms in the insane asylums in the United States, basically following in the footsteps of Pinel and Tuke. But she was active also throughout the Civil War, etc. Now, of course, that was not enough to absolve these or reform the culture of people running these institutions. And then in the 1880s, Nellie Bly, one of the most courageous journalists that ever lived, she, on one of her first major assignment, actually, she disguised herself as a mentally ill woman, got dressed up in tattered rags, didn't brush her teeth or wash her hair for a week or so, and walked around the streets of Manhattan. And she was and acted like she was insane, until that she was actually put into an asylum, a state facility, and then she started to be absolutely sane, and she was there for 10 days. And she act as a journalist, and she was actually had to be taken out by the lawyers of her employer, and she wrote about the abuses, the beatings, the bad food, the chaining, the etc. That, and you can actually find her book is probably available for free on all sorts of places on the internet. But an interesting book. So she was, this was in the 1880s, and that helped get more funding for these places. But I don't think that it really helped a huge amount, because there still was no real way of treating the people with serious mental illness. There was no medicines at all, and there was no other basic treatments. And this went on for quite a long time. and of course there was more and more people being put in. They became very large institutions. Some places there were some activities, but they're now called hospitals, and they had some sort of regulations. But until the 1950s, there were no medications. So in order to keep these people from being aggressive and hurting each other, physical restraints were commonly used. This is a picture in one of these hospitals. These men are wearing straitjackets, which kept people, except for the man in the back who was, or possibly the two men in the back who were the guards, but the three guys in the front were the people who are the guards. They were not actually prisoners, but they're just as much prisoners as prisoners were. So there was still quite a bit of abuse. This is a good picture of a straitjacket. As you can see that it was actually, this is the back of the straitjacket, where it was tied in from the back. The arms went longer than the arms, so the hands were not visible. And it was tied behind the back so that people could not move their arms. There were straps through the going around the crotch in order that the patients were not able to slip these things over their heads. Then, without medicines, there were other treatments were being developed in the 1930s and 40s. One of the particularly onerous and difficult ones was the lobotomy, where a doctor would basically put sharp instruments in through the eye socket to the brain and cut out sections of the brain. This was called a lobotomy. There were various types of lobotomies done, and until as late as 1957, 58, there was still articles in the peer-reviewed journals attesting to the efficacy of these procedures. Although most people who had these procedures, there was no way of knowing actually what parts of the brain were being damaged. And the other thing that was very oftenly used was electroshock treatment, which is used till today. Well, at the end of this lecture, we're going to mention that. And these were until the 1950s, when the first psychotropic or psychiatric drugs were developed. But the hospitals were getting more and more people in. By the time of the 1950s, over 1 million people resided in these facilities. In the 1960s, and when the people started becoming aware, the population in the 1960s became aware of human rights more than they had beforehand. And what was going on in these hospitals there, and people were not getting better, and they were being abused and sometimes getting worse. There became a movement to move the people out of these hospitals and have them treated in community mental health facilities. And that became the community mental health movement, which was basically, as we say here, an attempt to maintain new patients as outpatients and serve patients who have been released from mental hospitals on an outpatient basis. And the services were supposed to be comprehensive, but they were comprehensive mental health at the best. At the worst, they were not even comprehensive mental health. But it did get them out, not necessarily getting them out into housing. So that became where we have the street people who don't really have an ability to work or an ability to keep, but they in and out of hospitals. And of course, ever since that time in the 1960s, when the community mental health movement became legislative policy, then monies were cut off for state mental hospitals. Federal monies was cut off for state mental hospitals. State monies were cut off for short-term or long-term mental facilities for the mentally ill. And so only the very severest of the severe cases were given long-term treatment. And the only thing that was left, of course, is the community mental health. It is not necessarily a great system, as we can tell, because there are people who do not get the proper treatment, but there's other problems besides the mere structure. And but that is what we have today more than anything else. And even though that, as we can see here from 2013 meeting in Chicago, where the mayor of Chicago was trying to close down mental health clinics, and the people were protesting that to keep the mental health clinics, because without that there would be no treatment for people who are out in the community except for the hospitals themselves. As I've mentioned in previous lectures, the hospitals today are not there to cure mental illness. They are really not that much different in philosophy than they have always have been. It's in order to keep people who are bothersome to society out of the society. How is that done if they're not going to keep them out? The mandate of psychiatric hospitals today is to stabilize and discharge a person. The criterion for being admitted to a psychiatric hospital today is somebody who is a danger to himself or others, and will be discharged at the moment that he or she becomes not a danger to self or others. Okay, now we're going to talk about specific types of therapies or schools of therapies which are not for the major mental illness. We'll talk about psychodynamic therapies, in other words, Freudian therapies. We'll talk about humanistic therapies, behavior therapies, cognitive therapies, and then we'll go back and finish with the various biological therapies, medicines, which will go back to the major mental illness. We're going to talk first about psychodynamic therapies, which were based on the thinking and the writings of Sigmund Freud. We'll talk a little bit about Sigmund Freud also. And the reason why we start with Freudian therapy is because he was actually the originator of what's called talk therapy. Before that, there was no idea that merely by talking or talking something out, there would be a possibility of affecting psychological disorders. He assumed that all psychological disorders are a result of early childhood experiences and internal conflicts which arise from those experiences. In particular, he thought that there was either some sort of blockage or overindulgence of physical, or what he called sexual satisfaction or dissatisfaction during various stages of life from infancy on, and we're going to talk about those. Actually talked about in the chapter about personality. We talked about the various stages of the psychosexual development, and we also talked about the structure of personality, and you can refer back to that in order to refresh your memories. The idea of psychoanalysis, the basic idea in traditional Freudian psychoanalysis, it's not necessarily the way it's normally done today, is that the purpose is to for the patient to connect to and reveal the early childhood experiences that cause the conflict, and therefore get a handle on it and realize that the problems originate and really sit in someplace in the memory, and they should not be affecting today's life at the present time. Freud believed that once a person was actually aware of that, it would automatically change the behavior and the emotional and the thought process. Now, This is a very long and difficult process. It's called analysis, and psychoanalysis traditionally could extend for months or years, sometimes 2 or 3 hours, as they say, on the couch for many, many years. And with the purpose was through that to provide insight into the conflicts that are cause of the person's problems. In other words, insight is the realization that my problems are sitting and caused and connected to my emotional plight as a child, whether it was from some sort of trauma or indulgence or something like that. Once that insight is gained or something happens to with that insight that will make that connection, that intellectual to emotional connection, that's called catharsis. And often the catharsis could be a, uh, a highly emotional event, and it's when it was spilling forth of the repressed conflicts and the guilt. And this would happen. This is actually a picture of Freud's office in Vienna. Today it's a museum that anybody can go to. The couch, he's the heavy blinds, and the couch was one would sit on the couch. If you notice behind the couch, there is a large chair behind, so the patient would be on the sofa. The lights would be dimmed. The therapist or the analyst, in this particular office, it was Dr. Freud himself, would sit behind the patient, so the patient would not be affected, or theoretically not be affected by the presence of the or the reactions of the analyst. This did not actually happen. We'll talk about that in a minute. Okay, so this was Freud, and let's sort of like Freud is one of the most influential people of the 20th century, changing our ways of thinking about the human being, and so much so that he is characterized in many different sort of places, with toys and with ideas being spouted in his philosophy that it's your mother who caused all your problems because of the way she was, anything from breastfeeding you to scolding you, or your conflict with that. So, but in other words, he seems to be a figure greater than life. However, in truth, he really was a person. He is the introduction to his biography on the biography channel, which also is a recording from his only recording of his voice. You will hear in this particular thing about what he felt as in his life, his life's quest and his life's journey.
Trying to bring relief to my neurotic patient, I discovered some important new facts about the unconscious.
He found in the repressed areas of the mind what had been banished from conscious thought: fantasies of incest, fantasies of murder, repressed hatreds.
He is pushing sexuality back to a period when most people thought children were innocent, and extending the whole notion of what do we mean by sexual.
His reputation was that he was a libertine. He wrote pornographic materials, that he was a dirty, filthy, disgusting person.
People did not believe in my facts and thought my theories unsavory. In the end, I succeeded, but the struggle is not yet over. Sigmund Freud.
So we see here just a little bit of him as a real person. Let's go back to seeing a little bit more about the important pieces of his therapeutic process. Four important ideas. He would have the patient sit or lie down on the sofa and ask the patient to talk about whatever comes to mind. This was called free association. The concept was that if you talk without any input from another person, like you normally have in a regular day-to-day conversation, your conversation in a regular everyday day talk is guided and influenced by the social structure on where you are, or the social interactions of that particular conversation. The analyst was trained to reduce that guidance and influence and allow the person to free associate, to get, in other words, to gain access to thoughts which were controlled only by your own unconscious mind. Originally, Freud tried to use hypnosis to allow the clients to focus on these repressed conflicts. He eventually left that system and used only the idea of free association. He would encourage them to go deeper and deeper into more and more associations for any particular thought that would come to mind. During that analysis, the analysis was done by the analyst giving interpretations, which were short, possibly questions or conjectures about how these associations were revealing deeply seated feelings or conflict. Does that remind you of your mother? Is that sort of feels like what happened when you were a little child? Is it always such that you find it important to bite your nails, or when you get into that type of situation? These sort of interpretations were to connect what's going on in present day to things that happened in the past that were in the unconscious mind, where we saw things that were actually the seat of repressed and anxiety-provoking thoughts, ideas, and perceptions and memories. Now, Freud soon found that this wasn't an easy thing for people to talk about. They don't want to talk about these threatening ideas. It was not easy to pull out conflict that has been repressed and is hiding behind various types of defense mechanisms, as we discussed in the chapter about personality. This was called a resistance. The resistance was seen as a indication that this was actually something important. It sounds like you didn't really like your mother very much. Well, the client can say, well, no, Miss Dr. Freud, I don't think you're really right. I really do like this. This really has nothing to do with my mother. Well, that might be one way. That might be resistance. But if, on the other hand, the client would say, Dr. Freud, what the hell do you think you're talking about? You're out of your mind. You're bonkers. There's nothing to do. I don't even want to talk about that at all. What are you? You're getting pretty angry. That was a obvious idea that this hit on a very important emotional chord, and it was a threatening idea, and there is a real evidence of what we would call resistance. Now, another factor which became very important was the idea of transference, because many of these repressed feelings had to do with the relationships that the patient had as a child with their important caregivers, the mother, father, nanny, older brother, sister, uncle, whatever it was. And here you have the analyst, the doctor, the psychiatrist or psychologist, sitting in a place and a position of power and guidance. And it would be a normal and natural process that there would be a parallel process, a similar type of thing going on between the patient and the therapist, as parallel to the type of relationship that the patient had as a child with that important caregiver. This was called transference. In other words, the type of emotional valence that the person had as a child was now being transferred onto the therapist. And this would this way, the client would reenact the childhood conflicts, and the job of the analyst or the therapist at this point was to encourage this transference and to be able to reshape it, because now it is taking place as a reenactment of the childhood interactions. Of course, there's being this as according to Freudian psychoanalysis, this is a natural process. Freud easily found that sometimes the feelings of the therapist from previous relationships would be put onto this relationship with the patient, and that would be called countertransference, which was considered a countertherapeutic process, although something very, very important. One of the things that Freud was very content. So, for instance, if we see this particular dream here, for instance, this is a dream that, let's look at this for a while. So, if you look at this, think about the manifest content and the latent content. The manifest content would be actually what you saw in the dream, and what would be the screenplay of the dream. When you talk about the latent content, you might think of here the symbolic content that, for some reason or another, this woman seemed to be running away from herself, or running away from her desires of taking the apple, or punishing herself for desires for eating the apple or something like that. One actually can't tell unless you did the analysis and asked her to go deeper into her subconscious and her wish fulfillment. But you can see that there was some sort of symbolic meaning that might be read into or uncovered through analysis in such a dream. So that is the really basic idea behind typical psychoanalysis. However, the modern approach today is much briefer. It doesn't necessarily take years and years and years, although I do know people who have been on the couch for decades. Generally, psychodynamic therapists today will take a less time than years or months, and it will still focus on revealing unconscious material, but they don't normally sit face to face. They do normally sit face to face, and they don't necessarily use that lying on the couch. Traditionally, in Freudian, the therapist had very, very little directives, very little advice, very little input into the conversation, more than that very brief interpretation. Today, most even psychodynamic therapists are directive, and they have a lot more input. And in traditional psychotherapy, as we said, it's trying to take out the unconscious material. That would be the stuff which comes from the id. And today, most psychodynamic therapies look more on integrating the ego, which is the reality. In other words, trying to find a way of focusing and strengthening reality testing, ego-based therapy, rather than just connecting with the subconscious repressed material of the id. And that would sometimes actually be called ego analysis, or various other types of offshoots of the psychodynamic approaches. Again, we did mention some of Freud's students in the chapter about personality. Adler, Jung, Anna Freud, Melanie Klein, all of these people were students, and then there's students of students who went on to find or develop other types of modern psychodynamic approaches.